Hello everyone, I'm Dr. Angela Mattke and you're watching Ask the Mayo Mom on Mayo Clinic's Facebook Live. I'm a pediatrician at Mayo Clinic Children's Center, and twice per month I host a show about pediatric health topics where we take and answer your questions live. Today we are discussing rhabdomyosarcoma, a rare type of cancer that forms in soft tissue such as skeletal muscles or sometimes in hollow organs such as the bladder or uterus. Joining us for this discussion are two experts from Mayo Clinic Children's Center. Our first is Dr. Candace Granberg, and our second is Dr. Patricio Gargollo, who is also a pediatric urologist at Mayo Clinic Children's Center. They both have been active in our sarcoma group here, and we're very lucky to have them here today. It's going to be a great discussion, everyone, so please send your questions under the Facebook Live video feed, and we will try our best to review them during the live broadcast today. So Dr. Gargollo and Dr. Granberg, thank you so much for joining us today.
Thank you for having us.
Thanks for having us.
We also had one other member that we had hoped to make it, Dr. Carola Arndt, who's also a pediatric hematologist oncologist who's very active in treating children with sarcomas at Mayo Clinic Children's Center. And so we're going to start by talking about what rhabdomyosarcoma is. So I introduced it a little bit in the introduction, but can you give us a little bit more background on it?
Sure. So rhabdomyosarcoma is a really rare tumor. There's actually only about 350 cases a year in America. And as you said, it typically arises in soft tissues such as muscle, but it can arise actually anywhere. It doesn't play by any rules. It can be in the liver, it can be in the bladder, prostate, vagina, extremities. So it can kind of show up anywhere. And it's really something that typically comes more in children, but we certainly see it all the way into adulthood.
Okay. So what are the symptoms of rhabdomyosarcoma? We don't want to make parents overly concerned because it is a very rare tumor, but what would be the symptoms that would warrant them to at least bring it up to their primary care provider?
So like Dr. Granberg said, this tumor can happen pretty much in any part of the body, and really the symptoms have to do with where the tumor shows up.
Okay.
It happens in the head and neck, so some children can have anything from blurry vision to persistent headaches, sinus issues. If it happens in the extremities, arms, legs, it's usually persistently painful leg, persistently painful arm, or some weird new lump or bump. In the urinary tract or in the abdomen, children have a lot of urinary tract symptoms, problems urinating, and things of that nature. But again, because it can happen in any part of the body, the presenting symptoms can be pretty different for where it is.
Okay. You mentioned it can happen in adults. Is there a primary age group among children that we see it, or does it not discriminate?
It's usually early childhood. What we typically see as urologists are the urologic organs involved. So if we see a child with irritative voiding symptoms or blood in their urine, they don't have an infection, and then they're found to have a mass on their ultrasound, most of the time that would be rhabdomyosarcoma. So we certainly see it more in the younger children, but it can extend to the teenage years. And again, especially at Mayo, we have a very strong adult sarcoma program, so we see a lot of adults with rhabdomyosarcoma here.
Okay. So you mentioned a little bit of the testing, like blood in the urine, but what would we be looking to do, Dr. Gargollo, if we're suspicious of a tumor, and what else would we do to determine how extensive the tumor involvement is?
So the treatment of rhabdomyosarcoma has changed in the last 20 to 30 years.
Okay.
Certainly this is a lot of the chemotherapy part would be Dr. Arndt's. Unfortunately, she's out taking care of children with cancer, which we appreciate. But the initial treatment is, again, this usually presents with some sort of suspicious mass. So initially that's usually biopsied. So surgeon will go in, urologist will go in, take a very small piece of the tumor, test it. If it comes back positive for rhabdomyosarcoma, the next step is what we call staging. So staging just kind of tells you where the primary tumor is, how extensive it is, has it spread to any other parts of the body. So again, depends a little bit on the symptoms, but all children will get a CAT scan of their lungs to make sure there's no spread or metastases into the lungs. And depending on where the tumor is located, an arm, leg, in the abdomen or pelvis, they'll get an MRI. The reason for an MRI is that usually we can see a lot better what tissues are surrounding the tumors to just kind of plan for the next steps.
So it's better than like a CT scan in that area?
Again, it depends a little bit of whether it's near bone or not near bone, but it helps us plan the subsequent treatments, which once you have the staging, then the next step would be chemotherapy. So whether children are treated here in the United States or abroad in Europe, the first step is going to be chemotherapy, usually with at least what's called 3-drug chemotherapy. And then here in the United States, rhabdomyosarcoma patients follow pretty specific guidelines of how they're going to be treated and for how long. So once they're treated with chemotherapy, then usually what will happen at around the 9 to 10 week mark, is that they will get restaged. So then they get restaged, see what kind of effect the initial treatment had, and then we will either plan for radiation therapy or surgery to remove whatever remaining tumor is there.
Okay. So you mentioned that children in the United States often follow a pretty regimented approach, and that's due to something called the Children's Oncology Group. Is that correct?
Correct.
And can you talk just a little briefly about what that is? I know Dr. Arndt is our leadership at the Mayo Clinic for the Children's Oncology Group.
Right. So we're very lucky to have Dr. Arndt, who not only is our leadership here for the COG, the Children's Oncology Group, but also kind of draws the expertise from other centers. The Children's Oncology Group is basically a large group. Actually, Dr. Granberg serves in the COG. It's a large group of physicians, surgeons, radiation oncologists, hematologist oncologists that basically get together and decide based on, scientific evidence and experiments that have been done what the next best therapy approach is going to be for these tumors. And then those are set up in what's called the protocol. Children with different types of rhabdomyosarcoma, because there's not only different sites where the tumors can happen, there's also different types of rhabdomyosarcoma that can be, and again, depending on the site, depending on the type, and depending on a few other things, those children then fall on a very specific COG, Children's Oncology Group protocol, and that tells the treating center, whether it's in Florida or here at Mayo or Texas, that, it gives them a very specific roadmap of what types of treatments those children are going to undergo.
Okay. This sounds like a pretty extensive process, so I imagine it involves a lot of care team members. Who's involved in this process from the start to kind of the end as well?
Yes, it is quite complex. As Dr. Gargollo said, there's multiple treatment modalities that might be employed. So it really takes a dedicated sarcoma team that's experienced in these tumors to look at the whole picture and decide what's going to be next. So here at Mayo Clinic, we have a very dedicated team that consists of the pediatric oncologist, like Dr. Arndt and her team, pediatric urologist if it involves urologic organs, an orthopedic oncologist, which we have a couple of wonderful doctors here who are experts in sarcoma surgery. We have radiation oncologists who do not only external beam therapy, but proton beam therapy, which again we have here at Mayo. We're going to need to have a nurse coordinator who's going to help get all the outside films, look at the chemotherapy roadmaps. If they've had radiation already, bring those roadmaps in. And there's pediatric surgeons involved, depending on what organ's going to be involved with the tumor or what organs might be affected by the tumor. And we all meet as a group. We meet every other week, and we review outside cases routinely to see what's the next step, because not every case, really will follow that protocol that COG has, depending on how they responded. And so we review all those things to determine the next best step. And it's never just one person making a decision, here's the next step. To go along with that, if we're talking about starting chemotherapy or starting, the next step in treatment, which might affect their fertility, it's really important to talk to families about fertility preservation. So a lot of the chemotherapy agents that we use, or if there's any radiation near the organs that will be involved, or if surgery is going to affect their reproductive organs, we talk about doing fertility preservation surgery at the outset before any damage has been done. So a lot of times this happens when a child is going to get their port placed before they start chemo. And at that same setting, when they undergo anesthesia for the port, if it's a girl, talk about the ovary. If it's a boy, we talk about the testicle. We either take a portion of the testicle or the entire ovary on that side, and we can cryopreserve it for their future. So there's been some great studies, and I know we've talked about it on this show before, about the long-term outcomes of fertility preservation in prepubertal kids. So in the past, that wasn't really an option because we weren't sure how those tissues would respond when they're frozen and then thawed out. But we have some really great outcomes now, especially in ovarian cryopreservation, but also some really encouraging studies in testicular cryopreservation to show that we're going to give these kids hope down the road. So I think it's important to talk about outcomes eventually, and if we have, good outcomes in a cancer, we want them to live a full life afterwards, and that also involves their ability to have children if they like with their own tissue.
Just to clarify for families, so you're taking a piece of the tissue, cryopreserving it, and then when does the reimplantation typically occur?
So depending on when they need their tissue, so for girls and boys, we'd want them to be post-pubertal, or if they need the hormone supply from that tissue, it might be even before puberty. But certainly once they're well through their cancer treatment, they're not going to have any other effects from it. That tissue will go back into them. So that's an evolving process across the country. There's very few oncofertility sites that offer this, and we're all working together from the research aspect as well as the reimplanting the tissue aspect to determine the best timing.
Okay. So if families, since you said there's very few sites, if families wanted to reach out to talk to us about a fertility preservation program or the sarcoma program here, how would they get in contact with us?
So at Mayo Clinic, we have a phone number that they can call. It's 1-855-MAYO-KID. Otherwise, if you go to mayoclinic.org, you can go to request an appointment and you put in your information and put as much information as you can in there, saying the type of cancer your child has, need for fertility preservation, questions about proton beam, because maybe that's not offered at their site. As much detail that can be put in there would be best, and then we're very quick to turn around and call back and see if they're a candidate for coming here.
Because it's not something that can wait. You know, we don't
Correct.
want to wait and delay therapy and starting the cancer treatments.
And I would also say it is time sensitive because it's cancer, but it's also something that we shouldn't feel rushed into making decisions for these children.
Very good point.
They should be encouraged to make a second opinion call, and again, facilities should be able to make that call for them if they can. Call a site where they know that this is a high volume sarcoma center, or at least let the parents reach out and give them some time to look into where else they'd want to get an opinion.
Okay. So going back to the treatment, Dr. Gargollo, you kind of introduced the different treatment process and what goes through. Let's talk a little bit more about the surgical options, since you guys are obviously urological surgeons. What does it entail, and what would families kind of be preparing for this?
Yeah, so again, we mentioned briefly that the treatment of rhabdomyosarcoma has kind of shifted in the last 20, 30 years, and the primary shift has been not only improved chemotherapy, which we have, and improved radiation therapy when necessary. Dr. Granberg mentioned proton beam, so I'll talk very briefly about that, and then we'll talk a little bit about surgery. There's a few centers in the country that offer proton beam therapy. The nice thing about that, as far as your radiation treatment, is that you have a lot less surrounding damage to tissues. So, for example, if you're dealing with rhabdomyosarcoma in an eye, you don't want to radiate the entire skull. You may be able to radiate very specifically right behind the eyeball. So, again, really looking at expert centers that have a lot of experience with this, that do this very often. I think that's really, really key for our listeners, that hopefully they get the rarity of this really mandates a very good experienced sarcoma team. As far as the surgery, again, it depends a little bit it depends a lot on where the primary tumor is, but what I was talking about as far as the shift is that we try to do what's called organ-sparing surgery now, meaning that if there's a way to do local therapy to the tumor without removing a lot of surrounding organs or removing a limb, a leg, an arm, we really try to emphasize that now. That's a very different way to treat this cancer than it was 20 or 30 years ago, where people really would lose a lot of surrounding tissues and organs. So the primary thought process and the primary goal is for organ preservation treatment, to really try to not remove anything we don't need to remove. But again, depending on the site, certainly for us in urologic surgery, we actually deal a lot with abdominal surgery as well. The great thing about Mayo Clinic here is that we don't have just sort of a jack-of-all-trades sarcoma surgeon, which, again, a lot of great centers have. If it involves the extremities or the bone, we have amazing pediatric orthopedists that this is what they do for a living. If it involves the liver, if it involves the biliary tract or the head and neck area, again, we have very, very specific people that work on their areas of expertise, and this is all they do for a living, which is really important.
Which probably makes a difference in outcomes, I would imagine.
Oh, absolutely.
As well. Yeah. Absolutely. So when it comes to the surgery, just because the complexity of this type of cancer and stuff, what goes into planning and helping you prepare for the surgery?
So here we do 3D models for some complex tumors because we really want to see what other structures might be involved, so that we can talk to parents ahead of time what they might expect afterwards depending on what needs to be done. So what happens is you'll take a CT scan and you'll input that data into a 3D printer, and you're able to print an entire model that's actually life size. So this is actually the size of the child, so you can see exactly where the bones are, the bladder, the blood vessels, the spine, and in this case, the tumor is actually green. And so it's really tough to say, what are we going to be cutting near? How can we plan for this? When you're looking at a screen, you really needed 3 dimensions. And so we tend to plan these models ahead of time. We have a CT scan within 2 weeks of surgery, and it has particular parts of it that will go into our software system to print a 3D model. And we actually can even subtract some of the structures to get an even better look at what the tumor might look like. So for this particular child, it was very complex because this green tumor is intimately involved with the yellow bladder, with these blue and red blood vessels that are going to the leg, so that we could involve a vascular surgeon who would need to place a graft on those structures. We can talk about how we're going to reconstruct a bladder, and even behind here, which it's really hard to see, again, without the subtraction models, to see maybe there's nerves involved that our orthopedic oncologist is going to have to help do. So that's why we really utilize these in the pre-op setting as well as during surgery. We'll scrub out and go look at these tumors and turn them around in our hand and make sure we're looking at the right place. It's also very beneficial for families because we can look at screens all day long and scroll through a CT scan or an MRI and point to things, and it makes sense to us, but it might be really hard for a family to understand, especially during a difficult time, to know what all these structures are. So on the screen you can see on the left there's a CT scan, the yellow arrows pointing at a tumor, and the yellow circles outlining that tumor that's kind of right behind the bladder. But then when you put it into a 3D model, that big green mass is actually the tumor. So it's really, really impressive for a parent to see this is how big it is. It's filling my child's pelvis. There's where the yellow part is where the urine is collecting. This might be near where the bones are. So they understand who the team members are going to be, why they're going to be involved, where they're going to be cutting. And it's really important during surgery that you get a good sarcoma margin. You can't just scrape tumor out and take it out in pieces. You have to get all the way around it. So we really have to know ahead of time where we're going to go. So these are incredibly helpful for surgeons. It's incredibly helpful for the oncologists and the radiation oncologists to know where they're going to be beaming any protons, or in our case, we actually have a surgical suite that has intraoperative radiation, where we can beam some extra radiation doses just to a certain site right in the middle of surgery with the belly open, to go right in and cone in on where we have any concerns about where a tumor might be. And we do that all in the same setting. So these sorts of planning measures are incredibly helpful for everybody. Also, for teaching purposes, we have residents, medical students, fellows, people that are interested in cancer and sarcoma and surgery. And for them to be able to turn this in their hands is pretty meaningful and really sticks rather than just looking on a screen.
Yeah, absolutely. I bet that's incredibly powerful. Do the families ever ask to take these models home?
They do, and we always print them a copy to take, not really a souvenir, if you will, but so that they can keep it, and the kids like to look at it. We let them sometimes pick out their own color for a tumor if they want to, so that they can put this on their desk at home or take it wherever they're going. And we've had them take video and send it to family members because they're all over the country and they want to know what's happening with their niece, nephew, grandchild. And it puts it into perspective when they can see it kind of rolling around in the hands. This is actually how big it is. This is the structure that's going to be involved. Here's how we're going to plan to take care of him or her afterwards.
That's very, very powerful. So there are some new intraoperative surgical treatment options that you guys are involved in. Could one of you share with us some of the research that you guys are currently doing?
Yeah, so like Dr. Granberg mentioned, one of the things that we have available here is IORT, intraoperative radiation therapy, which really allows us to give extra radiation when needed. These sarcomas are particularly tricky if they're what are called relapse cases or progressive cases, meaning that you've treated these with chemotherapy, maybe radiation therapy, and for whatever reason that cancer has returned. Or if they've had surgery, there's an area where that cancer has grown back. Those relapse cases are particularly concerning and have a very poor long-term outcome. And the thought process is, why do these tumors come back? And we're working on that. But also, are we spilling very small pieces of tumor when we're doing the initial procedure, what's called microspill? And this is something that's been described in many other types of tumors, colon cancer, stomach cancer, where you remove the tumor, but for whatever reason, as careful as you may be, you're just sprinkling little tumor cells. And we know that because up to 60 to 70% of relapses or recurrences happen locally, meaning they happen right at the same spot, which again is just troubling and really tells us that we're doing something to kind of spill these small cells. With that in mind, what we've done here, which is extremely new, this particular procedure has been around for a while, and this is what's called HIPEC, H-I-P-E-C, heated intraperitoneal chemotherapy. This is a technique that's been used for, again, colon cancer, gastric cancer, ovarian cancer, where with the thought that we're having microspillage of cells, or potentially that we just can't see microscopic cells that are left behind, that once the child is asleep, we've removed all the tumor, removed the lymph nodes that may harbor some tumor, we actually put very hot chemotherapy, high-dose chemotherapy, directly onto the tumor.
Yeah, we have a picture of that.
And so we have a picture here, and what you can see on the left side of your screen is a heater, and again, this is not burning hot. You can certainly touch this chemotherapy, but it is warm enough because we know that when you activate chemotherapy, you heat it, we know it penetrates into the tissues. So we have a child who has undergone surgery, and that you can see on the right side. We put these special tubes called cannulas, which you can see those are those kind of V-shaped structures, and there's what's called an inflow cannula and an outflow cannula. The inflow cannula is up top. That brings the hot chemotherapy into the belly. It washes around, and you're really using this kind of like napalm. You're just trying to fry every little itty-bitty cell that may be around that may be able to cause trouble later, specifically because most of these kids, if they've had a relapse, if they had radiation, they're going to have radio-resistant, chemo-resistant tumor in there. It's going to be very hard to treat that. So again, we have that hot chemotherapy comes in, it washes around the belly. We do that for up to an hour. And then you have a sort of a constant flow. You can see there that gray structure in the middle is a pump. And so we have this constant flow of hot chemotherapy flowing through for an hour. And then after that, we wash all the chemotherapy out. We open the abdomen back up, or the pelvis, or wherever we may be working, and then finish the procedure, finish whatever reconstruction we need to do, and then finish the operation. We actually are the only center here to have what's called a phase 1 trial. So we have a phase 1 trial open now. It just opened about a month ago, specifically for relapsed or progressive tumors in the abdomen and pelvis for HIPEC. So we have a 2-drug combination therapy for a phase 1 trial. We have treated, I think, about 8 children or so. And thankfully our outcomes so far have been very positive. So again, that phase 1 trial is open, and again, we hope that we can offer something new for these children, because otherwise relapse cases, progressive cases are very dangerous.
So this is open to any child with relapse or progressive cases with an abdominal rhabdomyosarcoma?
Correct.
Okay.
So it's an abdominal or pelvic rhabdomyosarcoma, and we do have a couple different parts about the trial what people would qualify for it or not. You can see the trial in clinicaltrials.gov on the web, and it'll be there. You just have to probably type in HIPEC and it'll show up.
That's very cool. So I imagine recovery from the surgical resections can be sometimes challenging, and it probably depends on where the location is at. But can you talk a little bit about that and what families can expect?
Yeah, absolutely. What I tell families, especially for the HIPEC, is, again, you're putting hot chemotherapy into the body. The good thing about that is that, again, we are able to use a very, very high dose because it's not absorbed into the child's system. So you can use very high doses, but because this chemotherapy is heated, it causes the intestines to really kind of go to sleep for a while. That's called an ileus. You always see an ileus after surgery, but children that undergo HIPEC get what's called a persistent ileus, meaning they have it for a while. We've had children that have come back into their bowel function in 5 days. We have children that it's taken several weeks. So because of that, in order to keep their nutrition status optimized, we have intravenous nutrition, total parental nutrition, or TPN. All these children that undergo particular treatment with HIPEC will have TPN afterwards. And we've noticed that is the main issue we've seen afterwards. Certainly surgery has all kinds of different issues. The recovery otherwise is just like any major operation, and depending on what kind of reconstruction you're doing, are you rebuilding a urinary bladder? Are you, needing to resect a piece of a liver to get the tumor out, or a piece of stomach? Obviously, the recovery is a little bit different depending on those factors. But that's what we've noticed mostly with the HIPEC. And in children that have had radiation before therapy, that recovery tends to be a little tougher, meaning it's just a little lengthier.
Because their immune system's kind of already suppressed, and is that part of it?
Part of it, and the other thing is the radiation on purpose damages tissue. So you can have already kind of damaged intestine that then now you're throwing hot chemotherapy at, and then they can have that sort of persistent ileus that we discussed.
Okay. So you mentioned in 8 children so far in this phase 1 trial. But in general, what are the outcomes like for pelvic and abdominal rhabdomyosarcomas? Because this is more the area that you guys treat.
So it can be variable, again, depending on the subtype. We're learning a lot more about this cancer recently because of genetic studies on the tumor tissue itself to better characterize what the survival might be. I think it's important that every child is different. It's hard to just look at percentages and say, this is your success rate because of where it is, what stage it is, and how it's going to be treated. So we really emphasize that they need to be followed by their oncologist basically for life. They need to be enrolled in a survivorship program because, even if they have chemo and radiation and they're cured, they might have long-term effects from the treatments that will require seeing a physician, maybe in different departments. If you've had radiation near your bladder and you survive your cancer, you might have bladder effects later in life and have to see a urologist to figure out how you can optimize your bladder function. And that can go for the heart for chemotherapy, side effects, lungs, everything. So I think it's hard to just put overall percentages on things because parents will hang their hat on that. And we really want to just make sure it's individualized to their child, their tumor, their subtype, and stage so that we can give them a better idea once they fall into those categories.
Excellent. So you have both been involved with support for families and advocacy efforts. Can you talk a little bit about that?
Yeah, so there's, again, the tumor's rare, so advocacy and support, unfortunately, isn't as pronounced as it would be for breast cancer, prostate cancer.
Yeah.
There is a very active group on Facebook, which is a parent support group for children with pediatric rhabdomyosarcoma, and it's open only to parents, which is really nice, and that way people can, sort of share their stories, give each other advice. We've had a lot of people that have found us here, actually, through that Facebook group, and there's also certain sites on the Mayo Clinic website that will give you extra information. The Radiant Sarcoma Foundation, which funds some of our research, also has some information regarding rhabdo.
That's excellent. Anything else to add as we get near the end of our time and to wrap up our discussion today?
Yeah, I'd say that research is so incredibly important for this particular, in any rare tumor, that you want to make sure your child's tissue is being used in the right way. And so it's good that we have cooperative groups like COG where tissue is sent and analyzed, but we're actually doing a lot of really interesting research here where we're trying to identify more targets so that we can make better treatments for this cancer that are less toxic, that maybe have an immunotherapy aspect of it, so we can maybe give less chemo and give this immunotherapy, and they're synergistic in having a better response for the tumor. So it's important to find out what's going to happen with your child's tissue, and can it be sent somewhere else for somebody else to look at it, not only at the outset, but also if it recurs. And so, it's important for people to collaborate across the country to find better ways to treat this tumor. And so here we have a lot of basic science research. As Dr. Gargollo said, we have some grant funding to be looking at the basic science aspects of this tumor. And everybody is on the same page. We need to find better treatments for this rare tumor.
Absolutely. Well, thank you both for joining us today and sharing your expertise and sharing with our families that are watching as well. So thank you everyone who watched. You can catch the next Ask the Mayo Mom Facebook Live video and question and answer session on January 23rd, 11 a.m. Central Standard Time. The topic will be about vaping epidemic that is affecting many youth and adults and the potential dangers that are associated with it. Joining us for that discussion will be Dr. John Ebert, a nicotine addiction specialist, and Dr. Sophia Pillai, a pediatric pulmonologist. Thank you everyone who watched and have a wonderful day.